Good evening. I'm Dr. Rabail. I'm presenting this paper on behalf of Dr. Sana. And the topic of my discussion today is hemoglobin on admission as a predictor of outcome in head injury patients. I have no financial disclosures to make. So we all know that head trauma is a leading cause of morbidity and disability and death in our part of the world especially. And the aim of the neurocritical care, because when a patient presents to us in ER, he's already sustained primary brain injury. The aim of our study was to prevent secondary brain injury and to assess the risk factors that are associated with it. However, the only risk factor that we have worked on is to study the hemoglobin levels on admission of the patient, because the centerpiece of the secondary brain injury is hypoxia, tissue hypoxia. And hemoglobin, since it is the primary oxygen carrier to the brain, hemoglobin is very critical in preventing secondary brain injury. So hemoglobin is a primary determinant of brain oxygen content, and hemoglobin level can potentially act as a factor for determination of prognosis in head trauma patients. Since since the oxygen delivery of the brain is directly proportional to the cerebral blood flow and the oxygen content of the brain, the oxygen carrying capacity of the hemoglobin present inside the red blood cells act as a very major determinant of the outcome in a patient presenting with traumatic brain injury. The aim of our study was to assess the predictive value of hemoglobin level at admission on the outcome of the patients of isolated head trauma. This study was carried out in the Department of Neurosurgery in Jinnah Postgraduate Medical Center over a period of 2 years from January 2017 to December 2018, and the total sample size was 280 patients. All head trauma patients were included in the study, which were not of the pediatric age group, and any patient presenting with significant polytrauma, any coagulopathies, or on any anticoagulant medications were excluded from the study. The patients were classified into 4 groups. Group A consisted of hemoglobin levels less than 8 gram per deciliter. Group B had hemoglobin levels of 8 to 10 gram per deciliter. Group C had hemoglobin 11 to 12, and more than 12 then stratified into Group D. In our study, the prevalent gender was 84.3% were males, since males are more prone to traumatic brain injuries, and 15.7% of the females were included in the study. RTA, road traffic accidents, remained the major cause in 85.6% of the patients who were admitted in our department. 12.9% presented with history of fall, and 0.5% other causes. So we found out that 5% of the patients in a whole sample of 280 patients, 5% were included in Group A, which was the group in which the hemoglobin was less than 8 gram per deciliter. In Group B, we had 14.6% of patients. In Group C, 13.9%, and 66.4% of the patients had hemoglobin levels of more than 12 at admission. So the outcome of the patients was measured using the Glasgow outcome score, and it was measured in all different groups, all 4 groups. And we found out there was a statistically significant result on the outcome, the impact on the outcome of the admission levels of hemoglobin, because patients who were in Group A, around 64.2% had GOS of 1. That means these patients expired, and the remaining also had low GOS levels. Only 7.14% had a GOS of 5. In Group B, as you can see the pattern, that now the outcome is improving with improving hemoglobin levels. In Group B, only 36.5% of the patients had a GOS score of 1, and 31.7% patients had a GOS score of 5. In Group C, again, the pattern changed, and we had 46.1% of the patients in GOS having a GOS score of 5. And in Group D, 51.61% had a GOS score of 5, and only 27.9% a GOS score of 1. This was compared with the mortality, and we found out that Group A, the mortality was significantly higher as compared to other groups. The Group A is the group in which the hemoglobin levels are less than 8. Then we further stratified our study on the basis of male and female gender, but there was no significant differences in females or males, and the results were equal in both. On the basis of mortality, males, 31.7% of the males had died in the series, and 68.2% did not die. and 34% of the females succumbed to the injuries as well. In conclusion, I would like to say that hemoglobin admission plays a significant predictive role in head trauma patients with a significant p-value of less than 0.05, poorer outcome in patients with lower at-admission hemoglobin level, and more severe the anemia is associated with a higher mortality level. No significant difference in outcome between male and female gender was noted in our study. Thank you.
Thank you very much. Any questions? Yes, please.
Two questions. One is, at most institutions, 7 is the transfusion level. So you're the only group that was transfusibly anemic was your A group. So do you have a distribution of the hemoglobin values in that group?
We have the data, but we did not further stratify it. However, the patients who had a hemoglobin level of less than 6, they were transfused. But transfusion was not considered a parameter in our study.
No, I'm just wondering about the degree of blood loss because two issues. One, a hemoglobin of 8 is different than a hemoglobin of 4. Yes. And also anemia is often a sign of hemorrhage. And so the question is, was hypotension the cause of your mortality, or was it oxygen carrying capacity to the brain?
We were only going to focus initially on the hemoglobin level, and we're going to further stratify it on other things as well, including the hypoxia, the systolic blood pressure of the patient at admission, and any ICU care further that the patient needed, including any intervention that we did on the patients, whether they were operated or not, or whether they were transfused or not. But our focus on this study was just the hemoglobin level at admission and how it's going to impact the outcome. The other parameters we're still studying because the study is still in the process.
Okay, I would just strongly concentrate on that confounding of anemia for carrying capacity and anemia of hypotension.
Thank you.
Definitely. Would you like to have some comment?
I have a question.
So, any other question?
Yes. Did you perhaps find that there was an upper limit to the hemoglobin beyond which survival or morbidity increased?
Sorry, I can't hear you.
Did you find that there might be an upper limit to the hemoglobin beyond which survival or morbidity was affected?
We overall found out that patients who were anemic at presentation, who did not have any significant polytrauma, who did not have any other reasons for the low hemoglobin, they generally had poorer outcomes. There was no upper limit. We do not concentrate mainly on the upper limit, but we knew that the patient who were in the group C and D, they had prognostically good outcomes. So if I would want to comment on the upper limit, I would take it as around 11. Because that is
so do you think that morbidity or survival might be affected when the hemoglobin is high, such as in cases with polycythemia?
We do not study on that, but we do not study on the platelet count. We just focus mainly on the hemoglobin content, but it is possible.
Okay. Thank you.
Thank you very much, Dr. Kazi.